With regard to peri-implantitis, as you know, it's historically is an old and new disease. Actually, the more we do implants and the more we know about them, and in terms of the mechanical biological complications, probably you are the best person to talk about this topic, since you've been trained in a way to treat disease at the early stages of periodontal recognition as a disease and then as treatment. But as we do more, as you can see, probably get coming across a lot of peri-implant disease in terms of peri-implantitis or peri-implant mucositis. There are some statistics saying that 50% of people, they will demonstrate some sort of peri-implant mucositis. Other data recognizing that 1 in 5, 20%, they have got some implants disease or peri-implantitis. And the evidence is split between individual, patient-based, and implant-based. And I'm sure you, hopefully you will address this issue during your webinar.
Yes, I got some information about that in the webinar too.
Yes. So hopefully we will listen to your perspective in terms of recognizing and treating and managing, and how to prevent this problem in the future.
Can do.
From my own perspective, my feeling always, the peri-implant disease not necessarily starts as a disease, but could be a consequence or a secondary factor after having malalignment or malpositioning or mechanical complication. And once that is corrected, things could be reversed or could be stopped or ceased at some stage.
Yes, I'll have some evidence-based publication data about that specifically.
That would be good as well. Something always coming to our minds. So what we can do, especially as a general practitioner, when you face such complex disease, always you find yourself, well, what can I do? Can I reverse the process? Can I treat it? Can I save the implants? And we have got two camps, as you know, Steve. Probably, I'm not sure about North America. In Europe, people tend to sometimes replace implants, radical approach. And the other side, probably they try to maintain implants as long as they can to keep it.
Yes.
Yes, I do. So I think that's something, hopefully you will be able to give us insight into and enlighten us how and when we could address these issues, because it's quite a gray area in implant dentistry. It's not very clear. There's no clear cut. When should you preserve and save? When should you replace? And dilemma coming with the patients are not very well educated and versed into such options. Overall, there is a time and cost involved. So that's another issue as well, involved in the third dimension. Especially as you know, the implants is still within the private sector. Not all implants are state funded. So there is element of cost. And the patients always find it very difficult to face such a dilemma. And also alarming sometimes when you have got implants being placed 2-3 years ago and then you face a disease. It's very disturbing from the patient's point of view, from psychological point of view, from financial point of view, and time commitments as well, going and treat the disease. So hopefully things will be clear to us by the end of the webinar. Steve, I think we are almost coming to the 7 o'clock UK time. So if I may introduce you to the audience, and hopefully we've got a full house there. Hopefully the participants will come along. But I think without further ado, I'd like to introduce you to our present audience. And for this reason, ladies and gentlemen, it's honor and a great pleasure to introduce you Dr. Steve Wallace, a specialist periodontist from North Carolina. Steve, in trade, studied pharmacy.
It's 19 hours.
And then followed by a degree of dentistry from North Carolina, Chapel Hill, in the late 70s. And then later on, he worked as instructor at the university teaching restorative dentistry for almost 6 years, which is quite useful and it's quite important aspect, especially for periodontologists and periodontists. Later on, he carried out a specialist training at South Carolina for 2 years, and he studied periodontology at the MUSC. Since then, he is limiting his practice to periodontology and most of his work on implants, especially with the emergence of the implant dentistry in the early 1980s. Steve is involved in teaching postgraduate students and also dentists in the US. And he's been doing that since he's been as periodontist once he finished his training. And as I mentioned, Steve is a member of multiple societies in the US. And also he involved himself with many activities in North Carolina and South Carolina as well. So without any delay, Steve, the platform's yours, and hopefully we will give us some information and useful insight into the peri-implant disease, management of peri-implant disease, and vertical bone augmentation. Thank you, Steve.
Thank you very much for that kind introduction, Shahib. I'm pleased to be with the group today. And so without further ado, I will move right into our project, which we'll be discussing factors involved with peri-implantitis primarily, but that's going to involve soft tissue, bone, mechanical issues. And with an hour that we have, we'll touch on these. Of course, we have in-depth studies and courses that deal with those subjects in detail. So I'll move into that, and just to let you know, all images that we show have not been retouched for purpose of enhancing outcomes. As a general statement, we want to go from the left to the right. We'd like to A, stop peri-implantitis, B, restore bone and soft tissue support, and regain C, aesthetic. So those are three large criteria, and I will attempt to show you how we have accomplished that in cases with specific techniques today. So as Dr. Romid mentioned, why is peri-implantitis such a problem? Short discussion, it's number one, increasing prevalence. There are more and more implants being used, of course. Difficulty of diagnosis is a large stumbling block, and we'll speak to that today. Also, there's a potential for certain cases to exhibit rapid progression that are known as nonlinear progression. Also, no consensus for treatment protocol at present. That's a gray zone, as Dr. B mentioned. Financial impact of implant failure is significant. Patient happiness can be adversely affected, as you well know, as it can lead into extensive prosthetic reconstruction, which makes doctor and patient both unhappy. Just an example, if you look at the potential issues with placement of complicated prosthetics with implants, you can be looking at a course of treatment of 8 to 12 months or more. The cost of anywhere from $7,000 to $25,000 for small to complex cases. Whereas if you could just treat a single implant, not have it fail, and be stable long term, that was a huge financial saving. So over a period of the last 9 years, I've made it my objective to determine a protocol that would do exactly that. So what do we know right now? This would be a good time to review the basics of what we're dealing with. Anatomically, implants in teeth, of course, different, as we all know. Perpendicular fiber attachments into cementum for teeth. In implants, the fibers are parallel very different situation. Just to be complete, the clinical definition, according to the American Academy of Periodontology in 2017, it stated that it's an inflammatory process surrounding dental implants that is characterized by soft tissue inflammation and progressive loss of supporting bone. Etiology are more than these, but these are basics. Inadequate preventive care, failure to diagnose early, surgical and prosthetic errors. Then the ones that we deal with day to day is inadequate keratinized soft tissue support, inadequate bone thickness. So these factors we'll look into a little more in detail in this webinar. Implant surface effects are published and well known. De Bruin and the Rome consensus stated that rough surfaces, which all implants have, cause more peri-implantitis and bone loss than smooth surfaces. The existing periodontal disease patients are at risk for bone loss. As he was pointing out in detail, that infected peri-implantitis tissue is directly in contact with the implant surface. So that's our first cue. Surface coating is a smoking gun. We have to look at that. Periodontal pathogens, they're in the literature ad nauseum, so I won't repeat all of that. Needless to say, patients with a predilection for periodontitis are going to be prone to peri-implantitis. We can see that coming in patient history. Biologically, first stage we turn into is peri-implant mucositis, which is also evidence-based. Salvi and his group described this as reversible within 3 weeks. So that's where the early diagnosis comes in. That's good news. If you can pick up on peri-implantitis mucositis, the early stage, you've got a good opportunity to reverse and stop that. However, untreated mucositis is also documented by Costa and his group over a 5-year period. 44% of implants with mucositis develop peri-implantitis. No surprise, that highlights the importance of early diagnosis and treatment. So we'll get on to the second stage. As it progresses, you'll see these diagnostic features: probing depths of 5 millimeters or more, bleeding on probing, and up to 2 millimeters or more visible bone loss. And people can correlate that with 1 to 2 to 3 threads exposed, not covered by bone. In addition, you see presence of radiographic marginal bone loss beyond initial remodeling. That gives a little bit of differentiation between mucositis and peri-implantitis. So there are studies that are evidence-based that are helping us. We're trying to draw these together to build a consensus. So this is the typical clinical example of the probing depth issue, bleeding, radiograph showing exposure of threads. These are the type cases that we see routinely. Another is, of course, diagnostic suppuration. And many times you'll see this before implants are even uncovered for restoration. It can happen rapidly. That's where you get a phenomenon of a nonlinear progression. All cases don't progress at the same rate. That's a little alarming. And it's very difficult to distinguish which ones will, which ones won't. So, as with all things, we have to turn to evidence-based published data to guide us in decision making. So here's one study in 2013, early on, and this speaks to what Dr. Romid was talking about in the camps that are different in the way that they proceed. Parma-Benfanati and his group, their recommendation was implant removal is recommended when bone loss reaches 1/2 the implant length. That's not unusual at all. Many clinicians still adhere exactly to that criteria. Further studies, more recently, 2018, Mahdi and his group says, despite access flap surgery, application of a single decontamination measure, either chemical or mechanical, was not adequate to provide better treatment outcome. So this kind of speaks to the camp that likes to use peroxide, other decontamination methods. But that doesn't talk about the surface problem that you addressed very first of the webinar. 2020, this is recent success of implant treatment, 70% in this study, peri-implantitis. I'd like to present our data of 700 cases in a period of 9 years. We have replaced 7 implants. Now you might ask, well, how did you come about treating this many cases? Well, over the 9 years that I made it our focus and our objective in my practice to treat this problem and find the evidence-based data, that generated referrals to us as we began to see positive results from the evidence-based data that we had accumulated and developed a protocol from. So all of a sudden, lots of implants were being referred to us for treatment, and that's where all these numbers come from. So that's a little unusual, but that was good in 2 ways. It gave us a large body of cases to draw experience from and get the data that you see on the screen. Now, another factor that interested me particularly was, after reviewing the literature, I was seeing where treatment of many different kinds always resulted in, we consider, very minimal vertical bone regeneration. And to me, that was a huge factor, because without vertical bone regeneration, your results are compromised, particularly in aesthetic zones. Therefore, we did documented more carefully a 15-case series of most involved implants that we had, which would, by that I mean, there's implants that exhibited 7, 8, 9 millimeters of bone loss. Perhaps they had a supporting bone remaining of 3, 4 millimeters at most. These are the worst of the worst. We took these 15-case sites, treated them with our protocol to gain an average of 7.1 millimeters of vertical bone regeneration. Now that's a case series, this is not a study. We had so many cases, we were able to draw these out and focus on them to see, based on our protocol, what was possible. And this is what we found. So based on that, this is a pre-publication. I'm generating this data for publication shortly. So moving from that, let's talk about real world clinical applications, problems that we see, and rationale treatment. Implant fracture, pretty obvious. You'll see that not frequently, but you'll see implant fractures in different cases. So obviously it has to start over. You have to regenerate, do this again. Avoidable issues would be like this type of thing with inadequate separation in between implants. That causes die-off of bone and approximately due to compromised blood supply. That's an avoidable prosthetic issue. Laboratory procedures, manufacturing square crowns for purposes of aesthetics, many times will lead in turn to complications with peri-implantitis we then have to treat. Simple failure of non-seating of abutments and fixtures leaves gaps, and that can lead to infection, and peri-implantitis is generated. Another trap you can fall into is, not always, but it's very, very possible, if you approach very closely into or adjacent to the size of foramen, that can also contaminate an implant adjacent, turn it infection. There you have an implantitis case to deal with. And more in the line of periodontally speaking, inadequate keratinized soft tissue has been shown in multiple publications. Primarily Evidencebased and his group has studied this in detail and has some very good data to show that that's very important. So I'm drawing from our case series just to show you examples. of inadequate keratinized tissue and what that can lead to. Anteriors and mandibular arches you can see exposed. Maxillary anteriors exposed also. Lack of keratinized tissue, the very fragile breakdown, peri-implantitis. Then turning to the other hand, that you wash inadequate bone thickness. You have to have adequate bone thickness over implants to avoid exposure and infection. Very typical case that we see many times. Maxillary anterior implants. Very easy to place implants in the maxillary anterior and wind up with very thin facial bone. Studies that we've seen have already shown thickness of 2 to 4 millimeters is required for this not to happen. Another follow-up, it looked at period that the case was fine, but at the apex was not. Alpha bone led to a problem here to have to be treated. And then our favorite topic of all that we really like to avoid is retained cement. Retained cement around implants after seeding is a very, what we call a virulent factor in breakdown. Studies by Tom Wilson showed early as 2009, 81% of sites he inspected endoscopically showed retained cement. This is a factor that's eminently avoidable, but eminently findable in evidence. These are cases from my practice. All these cases I'm showing you are from my practice. In this case, we've seen 2 months following cementation, treatment required, and so this is what we find. A large band of retained cement generating an aggressive infection. Similar case, more of the same. Inadequate seating of the fixture and peri-implantitis issues from that combined with retained cement. This particular case, the aggressivity of the infection led to sinus infection and exposure. So these can progress, as we pointed out, more than a normally rapid fashion, nonlinear. Now, this is the rapid progression phenomenon that's been documented by Dirks and his group in 2016, and he showed that non-accelerating linear pattern can take place within 3 years of function. And we see this all the time. Naturally, we would, since we see so many cases, we pick up on this pattern regularly. This particular case had to be submitted, plant restored, case submitted over a period of time. No retained cement responsible, just a nonlinear pattern, accelerated very rapidly. Now, patient factors can play a role in this. Diabetics, smokers, natural progression of how that goes. Another case in a very short period of time, circumferential defect, aggressive, however, eminently treatable, which we're coming to. In some cases, go so fast that you can't treat them. Criteria is mobility. If you have an implant that's mobile, that's pretty much the end of the line, the kiss of death. I cannot rescue mobile implants under any circumstance. However, if you can get to an implant case, even bad looking as this one, there's not mobility, you have a good chance at not having to remove and replace this implant. These are typical cases: advanced bone loss, active breakdown of infection. These are reversible. Same thing as this, another nonlinear case, only 1 year after restoration. Bone losses up to 50% or more in this case. Not mobile, more. Another one, same kind of thing. 13 months later, after the case had been restored, 50% of implant bone support had been lost. So, as with everything, prevention is the #1 goal, what we're trying to do. So the factor number one is the surgical procedures in setting up cases for implants. We generate soft tissue thickness and support. Case like this, odds are very good around attachments for this type of keratinized tissue. You are not likely to get peri-implantitis. This is kind of an extreme example. However, it shows what the goal is. The goal is to achieve as much of this around implants as possible. Linkevicius in his multiple studies stated that 4 millimeters was his criteria. And that was very critical. 3 millimeters, like 90% different from 4 in occurrence. You wouldn't think that would happen, but he showed that in his studies multiple times. So in practical terms, surgical flap design, soft tissue grafts, surgical incisions. I know that the audience would like to hear about the details. Soft tissue graft split thickness dissection is optimal for a particular bone. Grafting procedures, full thickness flap flexion is required. Why is split thickness even done? Due to oxygenation of blood supply, which is critical for soft tissue graft to survive and do well. And an obscure study by Soltan and his group 2012 showed that in very detailed terms, the oxygen pressure gradient was very much higher if you had not reflected a full thickness flap and you had periosteum remaining around sites that you were treating. But this was huge. These are very obscure little studies, but these effects are huge. So this is where Dr. Linkevicius and his studies come in. He said, thick tissue biotype contributes to the aesthetics of an anterior. That brings into the next category. Treating and stopping peri-implantitis is one very important step. However, maxillary 6 anteriors, aesthetic zones, regaining that soft tissue support and bone support, that's the gold standard. And that's a little easy to say and difficult to do. However, case in point, I'll show some clinical cases to point out the techniques that can be used to accomplish both those goals. The particular case was a young patient had transitional implant had been placed at an early age as an intentionally transitional type of prosthesis, which is fine. Small crown. Now, at maturity, this was beginning to become mobile, and a more definitive step was needed. As you can see in this case, facial soft tissue contour is concave and it's not conducive to an aesthetic result. So in this case, bone support width and thickness was adequate. So an implant was placed immediately. A temporary abutment placed, connective tissue graft was harvested and used to fill out that facial contour. Bone grafts were not used because the bone thickness was adequate as it was. Soft tissue was deficient. So after healing with a temporary crown placed, you get this type of appearance. Then we have the advantage of long-term follow-up in a periodontal practice. So this went on, and we have to follow this up and see how that turned out in 2 years plus. So we're able to do an immediate implant, get this restored, soft tissue grafted, and gain an aesthetic result all at the same time. Another clinical case, this is a patient with a bonded bridge that did not want to have that any further. Used to have a prosthetic reconstruction, so floss and normal clinical procedures could be done. So the same type of procedure was planned. Here is her clinical appearance with bonded bridge removed. Soft tissue graft was harvested from the palate, connective tissue from a trapdoor type procedure, which we always use. And the same approach was taken. Immediate implant placed, bone width was adequate, soft tissue was not. This was a conservative flap procedure in which we did not use vertical incisions for purposes of maintaining maximum aesthetic. And this is a several years follow-up with that same, that's the ideal case. So we're not in a hurry to do everything at once, but when the opportunity presents, if you can maintain soft tissue integrity at the same time as placing an implant, studies that we show that your aesthetic outcome is improved. That was the rationale for exactly that. Case in point, this was a lateral that was lacking coronal support, could not keep a crown in place due to lack of retention. This was removed, replaced with an implant. Soft tissue deficiency was noted. That was planned for correction. And this was done in a little different procedure. Connective tissue graft was harvested from the palate as previous case showed. And in our practice, we maximize the use of biologics, so you can see along. Platelet-rich fibrin liquid is used in these processes about every case to maximize soft tissue healing. And that's what was done in this case. So the soft tissue graft here was placed in a pocket procedure. We did not use vertical incisions, have to place a flap and then make sure that it healed correctly with scarring. We're able to create a pouch underneath this area. Insert that soft tissue graft. Examples coming up in detail. Anyway, this is the bottom line, the result. Aesthetic outcome is #1 priority for anterior maxillary cases. Factor #2, adequate bone thickness. That brings up another whole category of clinical expertise beyond the scope of our webinar. However, touch the highlights. I'll let you know what we do. It helps. And this is we developed a super graft formula ratio, which has been shown to be very predictable and give us the results that we're looking for in these cases. On the screen, as you can see, it's a combination of mineralized particulate bone combined with biowash, which is not allograft, xenograft. In all the cases that we can, we harvest enough autogenous bone to equal 50% of that. And metronidazole for infection purposes used to wet this in addition to GM21, which is platelet-derived growth factor, and platelet-rich fiber. Now you might say, well, this is an awful lot of stuff to be using. Well, it is. We have found over the last 9 years, synergy of biologics is apparently having an effect that's greater than the sum of the parts. Our studies, we don't have studies to prove that or document that, but 9 years, that has been becoming more and more evident. All these things necessary to get the results that we're looking for? The answer appears to be yes. Now we'll change gears a little bit to augmentation. This is a case of an anterior maxillary reconstruction using a super graft combination like I just showed. In addition to, we needed to augment anterior contour and soft tissue, and we did that using acellular dermis, donor tissue. This is done in a little different way. We developed a technique to suture acellular dermis to the inside of a flap, this maxillary anterior area. And when that's done for the purpose of minimizing the chance of mobility between flap and graft. As you can see in a place like this, extensive damage has been done. Very difficult to stabilize the graft and then have a flap placed over that and not move together and disturb the clot. And that's the whole point. If you disturb the clot between grafts and flap, you have a good chance of complications. So if you, on the other hand, if you suture your donor tissue directly to the flap and then close it, makes more sense. Mechanically, you have a better system. That's what we do. Not that what we do is the thing to do, but it's a way, not the way, it's a way. Then grafts for use here. We've got a flap ready to be closed. It's already been augmented with soft tissue. That's been fully released. Thickness flap, of course, as we mentioned earlier. And primary closure, minimal lack of tissue closure is possible. Some areas it's not possible. To the extent that we can, close everything. And once this is healed, right, we take a CT scan. In this particular case, I'll just go through our steps. We select implant suitable. Case is closed at that point. Provisional is made. Final result. So moving into the actual technique of peri-implantitis surgical treatment, I want to talk about, present to you the instrumentation and technique that we have found over these past 9 to 10 years that have provided very positive results. The question is, to start with, why does this protocol work, which I'll be going through? And we believe and we feel that it's based on the result of the synergy of biologics, the interaction of substances, which is the definition of synergy. About 1 and 1 and 1 is 3, is 1 and 1 and 1 is like 6. It's different. That's just a clinical observation. We don't have the data to show that. However, we do know that we have evidence-based principles that implantoplasty results in clinically important defect resolution in advanced cases. Schwartz and his group published this in 2015. But this goes back to first discussed earlier about rough surface issue. This is the second time that's been mentioned. Evidence-based principle number 2 is regenerative procedures was effective in the treatment of moderate to advanced peri-implantitis. That was published in 2015 by Palmer Benfinati and his group. We've got two building blocks now. Number 3, this is a little different. RHBMP2, regenerative membrane biologics, has potential to promote formation and re-osseointegration in advanced peri-implantitis defect. Now this was stated in 1997, so this is not new at all. But many of these evidence-based studies are not made popular or evident. We have found this to be exactly the case. That regeneration of bone and re-osseointegration is apparently seen even in implants that we've gone around and removed all the rough surfaces, all the threads. That's radical. There's not many camps that would adhere to that. However, our case series documents and shows that is exactly what work, utilizing the biology of synergistic agents. This is a little unusual. This is a human autopsy study in which implant surfaces have been removed in a patient treated with bone grafting using a synthetic bone substitute. Post-mortem, they were able to obtain specimens, and they actually found new osseointegration through biopsy, histological analysis. So, what does that mean to us? That means that we treat implants by removing the surfaces, use the biological synergy that we feel is making a huge effect, you will get re-osseointegration. And our studies, our histological CT scans and others show that apparently that is what we're seeing. So, down to the nitty-gritty, what we really do, we treat peri-implantitis. These are the steps that we're following. Debride granulation tissue. Remove all threads and rough surfaces. That's radical. However, radical problems sometimes require radical treatment. Then we go on to polish and smooth titanium surfaces. No coating remains, no thread remains. Then titanium dust and debris is removed with glycine powder pressure spray. Surfaces then further treated with EDTA, ethylene diamine tetracetic acid, contaminants. The supergrafts is used, as we call it, to fill all defects as much up to the neck of the implant as we possibly can. Cover these with Infuse, which is RHBMP2. Overlay this with collagen GBR membranes to separate that out and prevent soft tissue ingrowth. So these are a lot of steps, but going through these, you will get the results. And we have documented that, so that's why we're excited to present this type of material. So I'll show some real world cases that we have treated that are typical. This is the type of thing that we deal with all the time. This kind of cases, you have 360-degree loss of bone, facial and palate wall, inproximal. Some remains, not much. Most of my colleagues would opt to remove and replace it. We've learned from experience, fortunately, in the majority of cases, we don't have to do this. Because our first step, as you can see, we've completely prepped this implant surface free of all threads, all rough surfaces, down to basic, smooth, polished titanium. This is then treated with EDTA, biologic growth factors, bone grafts, as you can see in the photograph. And Infuse is soaked into a collagen sponge and applied according to manufacturer directions. Recombinant membrane, morphogenetic protein. And this is covered with different types of membranes, resorbable, always resorbable. Then flaps release of the primary closure passively. So this was a CT scan taken sometime after this procedure, and it was showing an outline. It's bone is very difficult to see on CT scans, very thin. I outlined this so you could see exactly where it was. This shows how much bone that we have gotten generated vertically and horizontally from this treatment. Several years follow-up thereafter showing that that regenerated bone is supporting that soft tissue. That's how you can achieve an aesthetic outcome in cases like this where it appears not so likely. Another case in point is the mandibular anterior site with active infection, as you can see, no keratinized tissue at all. Debridement showed, and this is non-mobile, debridement showed that we're able to get all the material cleaned out, remove the rough surfaces, polish the titanium, and we went through the same procedures, grafted with the graft mixture that I described. Game being applied to one more biologic. We've got the synergy of biologics taking place here in each case. Bone graft now used to fill the defect. Infuse again. In this case, since the soft tissue was so damaged, we used the acellular dermis membrane for our GBR purposes, in hopes that we know it will generate keratinized tissue thickness. So follow up at a certain point in time, 16, 18 weeks, you can see a significant vertical bone regeneration. And this is not like one in a million. This is what we routinely look to achieve in these cases. And you might say, well, how does that look a couple of years from now? That bone stay or last? We take CT scans to verify, in fact, that it does. At 1 year post-op, this took the case period like so. So with the basics being shown, I thought it would be worthwhile to show a clinical procedure of peri-implantitis treatment in the maxillary anterior zone, typical type case. So as you'll see, just to not bore you with too many details, but access made particular spot. As in most of these cases, diagnosis is difficult. Many of these type things, you can see it appears like there's soft tissue adherence. Really not. Of course, X-rays can help show you that that's the case. In this particular one, as you can see, this is full thickness flap reflection. That gives us access to debridement of the defect and preparation of implant surfaces necessary. Full thickness flap bone grafting procedures. Now, one detail about this is we use Comet burrs. Comet makes burrs that are surgical length. Surgical length burrs are required to access very deep implant defects. We use them for that reason. They're all surgical lengths, so they give us the opportunity to remove rough surfaces and threads as far as they go, and have that left to promote further breakdown and recurrent infection. This is done very carefully. Water irrigation, not to damage any adjacent tissues with heat or trauma, either one. The purpose is to reiterate, the purpose of this is to remove any potential for retention of substrate that can cause infection to recur. That would be rough surface. Evidence-based data and literature shows that that's a hazard. It just seemed logical to us that, well, if that's a hazard, even though that seems radical, that must be removed. Treat a case like this, get a definitive result. That's some questions that I teach these programs in the States, of course. Patients, doctors taking these courses will say, don't you feel like you're weakening implants by treating them in this way? Well, we just go back to the data. 900 cases, how many implants have broken? 0. And that tells me odds are pretty good that no, we're not weakening implants to a degree that breakage recur. We haven't followed up every single one. We've never seen that happen. Particulate titanium dust has been shown to be inflammatory in nature. So debridement and removal of this is a step in the procedure. You can see that's an effort to make sure that much of that is removed as possible. It penetrates into the adjacent soft tissue. It takes a little work to remove it. EDTA is used to further cleanse and remove contaminants. The step after EDTA is Evidencebased, which is another biologic from pig teeth. Evidencebased is shown to promote bone regeneration and to increase in keratinized soft tissue. So, like I said, very valuable adjunct here, preventing return of peri-implantitis. So in this case, if we could regenerate A, bone support, and B, soft tissue support, and that produce a steady result, like we have a technique valuable to use. And this implant was treated on the palatal siding exactly the same way as you see on the facial. Photographic purposes, of course, it wasn't possible to show that very clearly. In this particular case, there's practically 100% of the facial bone has been lost. So we'll move into the regenerative steps. This is placement of Emdogain biologic. Emdogain is made by Straumann Company. Complete. It's used to coat implant, and after that, our mixture of bone grafts with biologics, also PRF, is applied. the membranes that we use in these cases are not tacked down or sutured in, either one. We found that careful approximation of flaps securely gives stability in these areas to the extent that we didn't feel like we needed to suture or tack membranes as areas. That's just a factor of experience and time. This is a PRF membrane being used over this particular site. PRF membranes have a pronounced leukocyte content that prevents infection potential. That's a plus for us. Obviously, patients are placed on antibiotics in these cases 1 day prior to treatment and for 5 days subsequent. Administer oral antibiotic regimen for them. And you don't remember from earlier, the bone graft material was saturated also with metronidazole antibiotic. That comes from intravenous administration in bags of sterile. So now that all this is in place, the next step is soft tissue flap approximation and stabilization. In this particular case, these are PTFE sutures, which are non-resorbable. We use those so that they do not resorb rapidly, we get long-term. The flap has been released apically enough to be passive, so reposition that very closely right around the neck of this tooth, recreate the aesthetics that we had to start with. Once the flaps have been approximated, PTF sutures, incisions that we've made, closed with chromic gut sutures. This is healing in an early stage, approximately 6 months after it's completed. I think we have a follow-up photograph showing several years duration. Yes, as you can see, over a period of years, soft tissue proliferation and maturation then more and more aesthetic. It turns out to be very patient friendly. So I want to thank London Dental Academy for the opportunity to present this webinar presentation for you and colleagues, and to point out that we're planning to have full-day peri-implantitis and soft tissue graft surgical courses available at future times. I appreciate your attention. I'm pleased to be here.
Thank you very much, Steve, for the brilliant presentation, very informative, evidence-based, excellent cases. I'd like to take some questions with your permission from the audience. And also, I'd like to ask a few questions myself. So I've got one question here, Steve, coming from one of our audience saying, please, could you talk about the impact of a prosthetic implant on bone loss? Is there any relationship between the prosthetic superstructure, whether it's a single crown, multiple restorations, linked, non-linked, regardless of the platform level, on the bone loss if any disease to develop? And here we are not talking about the biomechanical bone loss, Dr. Stephen. We're talking about on the biological bone loss caused by a disease.
Yeah, of course, you could spend a couple of days talking about that, but one comment I would make would be that the platform switching of implant platforms has been shown by Linkevicius and others to be beneficial. That speaks to one topic, biologically and prosthetically, immediately. But we do use that in our practice get that benefit?
Steve, I found from my own humble experience in the past with dealing with different systems and different levels when it comes to restoring dental implants. I always tend to first stage of treatment is to remove the superstructure. That's the first. Put cover screws or healing abutments. I prefer healing abutments first, and then I put remove prosthetics, partial denture or full denture on the top. Then I would ask my hygienist to go and to have some conservative closed debridement for a few sessions. And then later on, I decide what type of intervention I will take, what route of action. Rather than straight, I will hold fire, not shooting from the hips, and make sure that I get a grip of the disease, because sometimes you don't know what's going on. It could be like acute infection, and that would resolve by itself. The other dilemma is, as you know, the topography about the bone around implants, 3 dimension, is very, very complex. And there is no diagnostic tool up to date to tell us exactly what sort of topography of bone loss around the implants, unless you open flap, which is not in our favors, especially with bone loss and vascularization and the topics and the things you talked about. So my first line of treatment, remove superstructure, and later on, in my hands, in my area, I would try to change if the superstructure was not designed properly, i.e. most of the implants I see from 1980s and 90s, old Brennemark extended hexes, done in a way either cement retained or screw retained at fixture level. As you know, the old type of implants, as Albertson mentioned, you will expect some bone loss 1.2 and then 0.2, and then that was acceptable. But on the other side, I tried to go through TMAs, transmucosal abutments or flat tops, which historically were present and nowadays multi-units. That would help change the whole, I would say, is a game changer in terms of managing the disease. And then a later stage, I will address the disease by itself. How can I go around if I want to regeneration, non-regeneration, soft tissue management. And again, it's a dilemma here whether you go for soft tissue enhancement by itself, since the implant, even 50% bone supported, does not mean the implant will get loose or mobile, because as you know, osseointegration is binary. Either you have osseointegrated implants or non-osseointegrated implants. So the implant will stay, but how can you enhance, especially in the aesthetic zone, based on the prosthetic? So I don't know what. Sorry to take. It's a quite complex issue to deal with in one shot or in one discussion. From your point of view, is that something you will consider, or you go straight from your perspective as a periodontist? I've got a problem, I've got a disease there, and I need, as you mentioned, radical problem needs a radical solution.
Yeah, I guess I understand what you're saying exactly. And based on the cases that we've done over 9 years, I tend to treat immediately, opposed to treating prosthetically and trying to get a result or a change. If I'm seeing infection and bone loss past 3 threads, my indication is to open that area, treat that definitively, and stop it right there. However, you know, Linkevicius tells us soft tissue is a big deal. So if you've got these external hex implants, your hands are tied. That's unfortunate. You're sort of stuck with that. So that leads you to surgery automatically.
And Steve, I'd like to ask you another question myself. What are your thoughts on treating like what some people, especially in Europe, managing the lack of hard soft tissue by another augmented surgery using soft tissue techniques, i.e. pregingival graft, de-epithelialized, or connective tissue graft, or even a soft tissue substitute, for example, like a biomaterial? Is that something you would consider, or always you think about, I have to put a combination of minerals, bio-os, antibiotics, then soft tissue on the top of it to enhance and to create scaffold around my fixture?
Yeah, that's I think in answer to that, our approach to treating peri-implantitis, since it's been such a very difficult topic, a difficult clinical situation to, one, stabilize, and two, to even think about reversing. That's where we turn to synergy of biologics using multiple things with grafting plus soft tissue to get the desired result. Now, it's not in an aesthetic zone. That's a different ballgame. You don't have to worry too much about gaining a lot of soft tissue and gaining a lot of bone support. You just want to stop it. So it can be two different goals depending on clinical situation.
Right. Last question, Steve. Sorry about a lot of questions, and this is an opportunity for us to
That's quite all right. We all have more questions than answers.
treated many cases, and with the new systems emerging into the market, there is a plethora of implant system coming, but all based on pretty much similar biomechanical type of arrangements or configuration, I would say. Have you found any difference in terms of the shape or the design of the implants in terms of disease progression, i.e., just I mentioned, the conical interface along with the hexes, the platform switching of the implants, the shape of the implants, whether it's designed to be a conical, tapered, or power implants, and whether what some companies allegedly claim that having different surface treatment will give you different outcomes. For example, etched and blasted, smooth, micro threads, laser locked, all these type. Have you come across any difference from your experience? Because of the cases you mentioned, you showed us today, most of them, they are, I would say, threaded implants, and
Yes.
most of them are parallel implants. And I'm not quite sure about roughen because it's quite difficult to see from the pictures. But most of your cases coming, I would say, 1990s type designs implants. I haven't seen anything which nowadays coming into the market with the new strong, I would say, claims coming from the companies that these are better designs, give you powerful type of healing and also better to resist disease in the future, since there is a better configuration of these implants.
Exactly. I know what you're saying. Well, I'd make this comment. I think that it's obvious that the competition between manufacturers to create a better implant surface porosity and say mine is better than yours, I think that's what got us in this problem to start with, frankly. The reason that I say that is a study that I didn't mention, but that I know that I'm aware of, 30-year-old study of turned machined implants. They found peri-implantitis at an extremely low rate over a 30-year period. Therefore, that tells me, based on the data we saw, study reporting the influence of roughened surface being negative, it's hard to say that that's a really good thing. Now, the only exception that I'm aware of is BioHorizons specifically has laser etched neck implant surfaces that they do have direct evidence-based data research that shows soft tissue attachment into that. But that's a plus. That's the only exception I'm aware of.
Right. Okay. I've got many questions, but I have to close the session. Thank you very much.
I'm glad you could have had the interest to ask. That's all right.
I think we have to probably arrange another webinar, hopefully sometime, with more about implants and your preferences about implants, implant designs, and protocols you follow in your practice. I'm sure.
Oh my gosh, yeah, you could spend a little time on that. Yes.
We'll be looking forward to meeting you sometime soon. But thank you very much, Dr. Wallace, for your time and joining us from North Carolina. Hope you enjoyed the rest of the day, and thanks for everybody attending the session today. And just to remind you, our session is recorded and will be podcasted on the Facebook page for London Dental Academy and YouTube as well. Thank you very much, everybody. And
thank you very much for having me. It's been a pleasure.
My pleasure. Thank you very much indeed. Bye-bye.
Bye-bye. Bye.